Sorry, I ran out of time on that last slide. So this is the last one regarding pupils. So a mnemonic that we use to talk about the pupils is pearl. If the pupils are pearl, it means they're equal, round, regular in size, and reactive to light. So you can say that they're constricted, they're dilated, or pupils are pearl. Some people do say perla, but pearl works just fine. So neurovascular status, you want to provide a hands-on assessment to determine sensory and motor response. Typically what it's going to be is you put both of your hands out and say, hey, I want you to squeeze my fingers at the same time or squeeze my hands at the same time. So you're checking for the motor response of them actually being able to squeeze, and then you're checking to see if the strength on each side is equal. You want to try a thorough sensory assessment. Typically what we do is like take fingers and rub on the insides of their arms at the same time saying, can you feel this? Does it feel the same on both sides? If you have their shoes off, you can always grab a toe and say, which toe am I grabbing? Have them close their eyes so that they are not watching you. Even if you do just the rubbing on the inside of the arm or the inside of the ankles, you want to do that on all four extremities as well. So you'll compare the upper extremities to each other, and then the upper extremities to the lower extremities, and all the way around. Anatomic regions, this is doing our head to toe. So we're going to start with the head, neck, cervical, spine, except on kids. On kids, the younger they are, the more important that this is. But on kids, we go head or foot to head because they tend to get a little anxious when you come straight for their face. But you're going to palpate the scalp and skull, looking for any blood or any crepitus. Crepitus is kind of like that sound that Rice Krispies make when you put milk in and they kind of pop and whatever. You want to check the patient's eyes, check the color of the sclera. The sclera is the white portion of the eye. You want to assess the patient's cheekbones actually by physically touching them. You have to physically put your hands on your patients. We're not giving them a once over and calling it a day. Literally, we are touching our patient. You want to check the patient's ears and nose for fluid. If there is an orifice or hole in the body, we need to check to see if something's coming out of it. So nose, ears, mouth. Obviously, we need to look at the genital area to see if they're incontinent of urine or stool. If they have another hole on their body that is like an injury, see how bad the bleeding is out of it. Now, if they have a nose piercing or piercings on their ear, wherever else people put them, that's not what I mean. I'm talking about a natural or injury type orifice or hole in their body. You want to keep going. You want to actually look at the upper jaw, the maxilla, and the lower jaw, the mandible. Have them open and shut their mouth to see if you hear any cracking or popping. You want to actually have them open their mouth. You want to visually inspect for broken teeth. And if there's an unusual odor from the mouth, you want to check that as well. Smelling alcohol on the breath. If the breath is unusually sweet smelling or fruity smelling, that could indicate that they have something wrong with them as far as blood sugar. Not everybody can smell the fruity smell. It's actually called ketones. There's a very small part of the population that cannot smell that. I'm one of them, but I can smell bone marrow transplants. It smells like creamed corn for all of you wondering what that smells like. Most people can't smell that. When you go to the chest, you do the same thing. You're going to inspect, you're going to visualize what's going on, you're going to palpate for stability. You want to watch both sides of the chest to make sure that they rise and fall together. When you start breaking ribs, things start going different directions than what they're supposed to. You want to observe for normal breathing signs, and then during your head to toe, like the 90-second quick, let's get this done, we don't actually auscultate. That will be a little bit later when we do a focused. Your abdomen, you want to palpate for tenderness, rigidity, meaning that it's hard, or the patient is guarding. They'll kind of pull away from you as you go to touch it because it hurts. They don't want you to touch it. You'll go through all 4 quadrants, and this is not I'm going to just lightly touch my fingers on all 4 quadrants. You're actually going to push in with the heel of your hand and then roll over towards your fingers, push in, roll, and do that for all 4 quadrants. Pelvis, you're going to look for symmetry and then any obvious signs of deformity. Your pelvis is kind of like a big book. So you want to grab the outside of the book and you want to push it in to make sure that it doesn't close on you all the way because it shouldn't. You want to push back on it to check the back portion to see if there's instability there. That would mean that the front portion of it is not doing so great. And then kind of rock it back and forth. Extremities, you're looking for DCAT BTLS on everything. You're going to check pulses, motor, and sensory on every single one of your extremities. So can you wiggle your fingers? Can you wiggle your toes? Push up, push down, squeeze my fingers. And does this feel the same on both sides? What toe am I grabbing? What finger am I grabbing? And move on. Posterior body, this is the one we forget most often, but you need to check for DCAT BTLS, symmetry, open wounds. You're going to palpate from the top of the neck down, asking for any tenderness, feeling for any deformities, any step-offs. Your spine has bones that have a spinous process that comes off. That's the bony bump that you feel, and they align pretty good. If you're going down and all of a sudden one of them's missing or it's protruding, obviously there's an injury there. We then want to assess the vital signs using an appropriate monitoring device. Technology enhances our assessment. We should always do an assessment before we include any sort of technology because it's not replacing, it's enhancing. What this guy has on his finger is an SpO2 sensor. It measures the amount of hemoglobin in the blood that is bound to something. While we would prefer for it to be oxygen, there are other substances, carbon monoxide, for example, that binds with a higher affinity than oxygen. Hemoglobin likes carbon monoxide much more than it likes oxygen, unfortunately. So they're going to bind together if that carbon monoxide is present. 93% is what it's showing for him, so 93% of his hemoglobin is bound to something. Now that's a little low. We would like to see 94 or above. The 73 is his pulse rate. It gives us both of them. Patients with difficulty breathing or complaining of shortness of breath, we give them oxygen even if they're satting 100. They have 100% saturation. If they say that I'm short of breath, we will give them oxygen. Remember that shortness of breath is a symptom, something that you can't actually measure. It's not a sign. Capnography, this is a quick and easy way to see how well your patient respiration at that cellular level is doing. This measures the amount of carbon dioxide that your patient breathes out. If there's a normal range for that, 35 to 45, depending on the physiological state of the patient. Most of you as EMTs won't have to worry about capnography so much. As ALS, we definitely delve into that a lot more. Checking blood glucose, this measures the amount of glucose in the blood. For normal people, like that don't have diabetes, a number above 60 is good. We would rather see it 80 to 100. That's kind of what we would say is normal for most people. There is a skill drill on this, and we will go over it. Non-invasive blood pressure. There are invasive ways where you actually stick sensors into the body. We don't do any of that. We are going to take a blood pressure cuff, be it manual or be it automatic, and we're going to check it. If the patient's blood pressure is irregular, don't continue to rely on your equipment and take automatic after automatic after automatic, because it may not be the patient's blood pressure that's off. It may be your technology that's not working. We want to reassess our patients, especially if we do something to treat them. We want to make sure that that's going okay, that they're either getting better or that they're not getting worse. So we repeat the primary assessment, we reassess vital signs. On every patient that you transport, you should have a minimum of 2 vital signs. You want to look for trends. Are things staying stable? Are their vitals getting better? Are their vitals getting worse? You want to reassess the chief complaint. You want to see if any of those treatments that you're doing are making them feel better. Has anything gotten better? Has anything gotten worse? Is something else different going on now that we're actually treating you? Check your interventions. If you've made a intervention choice for A, B, or C, you need to go back through those quite a bit. You want to make sure that everything that was bleeding is under control now, and you want to assess if you need to be a little more aggressive for your patients if what you're doing isn't changing their status. Identify and treat any changes in their condition and document any changes. If it's going well and it's making them better, document it. If it's making them worse, document it. If you can do something about it, document it. If you can't, drive fast. Reassessment. For unstable patients, those are those that have problems with A, B, or C, or the ones that are critical and could potentially have life-saving consequences if we don't check on them regularly. You want to take vitals approximately every 5 minutes. 3 to 5 minutes is a good baseline. The more critical they are, the more often you need to check on them. If they're stable, every 15 minutes is fine. This is all of Chapter 9. Go ahead and look at the summary of your slides later.